We begin by making a small stab incision into the anterior chamber with a tiny sharp knife. Lidocaine has been injected into the eye, and you can see viscoelastic being injected into the eye. This is a material that will keep the eye from collapsing when an incision is made. A small instrument is placed through that small incision, and now a 2.6 millimeter half-thickness clear cornea self-sealing incision is being made temporally with an instrument we call the keratome. As you can see, the eye does not collapse. This is a trapdoor incision that seals itself. A bent needle is now being inserted into the eye, and a slit is being made into the anterior capsule of the lens. You then push on this slit until you create a small flap. Another instrument is then inserted through this self-sealing incision. These so-called capsulorhexis forceps now grasp this flap, and the capsule is torn so that a perfect circle is created in the anterior capsule of the lens, the front capsule of the lens itself, almost as if it was cut out with a cookie cutter. This flap is being torn and then regrasped, and then torn for another segment, and then regrasped and torn. And you can see the capsulorhexis is now just about completed, and the piece of anterior capsule has been removed from the eye. There's a perfect circle cut in the anterior capsule. Balanced salt solution is then injected under the anterior capsule to separate the hard central nucleus from the softer cortex that surrounds it. The lens has a structure rather like a peach. There's a hard pit in the center and soft flesh or cortex in the periphery, and there's a skin around the lens which we call the capsule. The difficult part to remove is the nucleus. We used to take it out all in one piece. As you will see, we are now going to take it out by turning it into the consistency of a milkshake and then sucking it out. This small instrument that's being inserted in the stab incision is a chopper, and this is a phacoemulsifier. It has 3 different settings in the foot pedal that controls it on the floor. You press a little bit and it squirts, a little more and it sucks, and then the phacoemulsification is activated. The phacoemulsifier is now being used simply in its suction mode, and the soft cortex is simply being vacuumed up so that the harder, darker colored nucleus is becoming evident. Now the phacoemulsification is activated, and the phacoemulsifier is driven right into the center of the hard nucleus. Now the phacoemulsification is stopped, and the chopper has been used to chop the nucleus in half. Now it's in thirds. The phacoemulsifier is now digging into the nucleus again, and as you can see, the nucleus is literally vanishing. Phacoemulsification is reducing it to a soft pulp, and suction is removing it from the eye. Now the chopper is being moved to rotate the nucleus around, and once again the phacoemulsifier is activated, and down it goes into the very center of the nucleus. Phacoemulsification then stops, And the chopper is used to separate off some more chunks. We are literally eating up this nucleus as if we were eating pieces of a pie. Now we have a chunk of nucleus brought into the center, and the phacoemulsifier is gobbling it up just as if it was a piece of cheese. This is a very powerful instrument, and it's very good at gobbling up other portions of the eye. So it must be used with extreme care. You will notice I'm keeping this phacoemulsifier tip right in the center of the eye and feeding fragments of the lens nucleus into it with the chopper. Another segment of nucleus being eaten up. Now I am removing the chopper from the eye because the nucleus itself has been removed. This is a blunt instrument. I am now going after the epinucleus. Phacoemulsification power is way down. Suction has been reduced. The epinucleus is the layer lying right around the nucleus. It's much softer and it's easier to take. I'm now using the second instrument to mobilize the epinucleus that was next to the wound, and the phacoemulsifier again is sucking it up. Very low power is being used here because this is very soft material. A little more of the epinucleus. Notice that the second instrument is being placed underneath these fragments. This is to keep back the posterior capsule. After the phacoemulsification is completed, another instrument is introduced in the eye. This is the irrigation aspiration unit. It squirts and sucks. The squirting is from the larger holes. Suction is from the little mouth in the center. And this instrument is gently grabbing pieces of cortex and tugging them up and sucking them out of the eye. This is the part of the procedure that appeals to people who enjoy vacuuming their apartments. This must be done extremely gently because it's very easy to suck up pieces of the lens capsule. We are trying to leave that lens capsule intact so that it will form a living pouch for the insertion of the artificial plastic lens that will be replacing the cloudy lens. Approximately half the cortex has been removed. I am very gently pulling it out. Now I am splitting the functions of irrigation and aspiration in order to get the cortex that is right underneath the incision. This is called a Simcoe. Irrigation will be through the self-sealing incision, and aspiration will be through the side port. There goes irrigation alone. This is no longer aspirating. And this second slender instrument is now aspirating. It will go under in an area that would have been difficult to get any other way. And again, there's a section of cortex being pulled out. More cortex going, more cortex going, more cortex going, bit by bit, patiently and slowly, avoiding at all costs the capsule. And successful completion of removal of the nucleus and the cortex through an incision that is 2.6 millimeters in diameter. You can now see the punched out incision in the anterior capsule. Viscoelastic again being injected to push back the capsule that is posterior and create a nice opening for the intraocular lens. The intraocular lens will be used in this case is a foldable lens. A little more viscoelastic going in of a slightly different variety. This foldable lens has been rolled up like a piece of paper and placed into an injector using the second instrument to brace the eye. The injector is slowly wiggled into the eye through this 2.6 millimeter incision. And now, slowly, this folded up lens, which will be coming out just like a little shrimp, will be introduced into the eye. This lens has only been in use for about 6 months. It's made of polymethyl methacrylate, a material that is entirely inert in the eye. There comes the lens, like a little embryo, and now it's flexing its arms and legs and opening out and uncurling. You can see that it has 2 feet. These feet go into the capsular bag and center the actual lens itself, which is the part that will restore the focusing power to the eye. The lens is now not completely in good position. I'm gently maneuvering it to get the lens so it's perfectly centered. And there you have it. 2.6 millimeter incision, implant in perfect position. The only thing now to do is to put the irrigation and aspiration unit back into the eye to remove the viscoelastic, because viscoelastic will cause the pressure to go up. Remember, this is under topical anesthesia. The patient can move the eye freely at any time. This patient is cooperating well. Sedation has been used intravenously. Viscoelastic is being carefully removed to avoid a pressure rise. This entire procedure took 17 minutes. The patient walked out of the operating room without a patch, seeing well out of the operated eye, with no incisions. Since the incision is not closed by stitches, no astigmatism is induced. There we have it, all completed. The day after the surgery, when the patients walk into my office, I have to look at my chart to remember which eye was operated on, because the 2 eyes both look normal.